Hi everyone, welcome to Women's Health with the Listening Midwife. I'm Day Day, aka the Listening Midwife, and today my guest is Natalie.
Hey!
Thank you for coming back to talk to me again about your birth experience. We're really excited to go into today's topic. Tell us a little bit about what we're going to be talking about today.
Placental abruptions.
Okay, brilliant. So for anyone who doesn't know, placental abruption is when the placenta starts to come away from the lining of the womb where it's stuck to. And that can cause bleeding from where the placenta is coming away. And that is an obstetric emergency. And we move very quickly when we diagnose abruption because it can obviously cause a lot of problems. So without further ado, let's talk about it. Let's talk about, first of all, your pregnancy. So what number baby was this? And tell us a bit.
This was number 3.
Okay.
My second son, Cairo.
Cairo, lovely. And for those of you who haven't seen the previous video, we talked about Natalie's second pregnancy with Cavani, who had oligohydramnios. So definitely go back and have a look if you haven't seen it. So how long was it between your second and your third pregnancy with Cairo?
13 months.
In this pregnancy, was it classed as high risk? Was it low risk? Were you midwife led?
Yeah, it was high risk.
Okay.
Yeah.
And why was it high risk?
Because I'd had the oligo just a year before.
Yeah, fine. So oligohydramnios is usually associated with babies being small as well for the gestational age that they are. And that's what happened in her previous pregnancy. So what did that mean for you in this pregnancy? When knowing that you were high risk, what did they tell you was going to be the management plan for the pregnancy?
More appointments, more scans, more bloods. Literally.
More of everything.
Yeah, more of everything. Literally.
Fine. So you were having more appointments with your midwife, as well as more appointments in the hospital with your doctors and growth scans to check on the growth and development of baby. Yeah, perfect. And I think they were hoping that you wouldn't develop oligohydramnios again. So
they wanted to rule that out quickly.
Yeah, so they're keeping a close eye on that. Perfect. So how was the pregnancy for you?
In the beginning, it was fine.
Yeah.
It was tiring because I had the baby already. He was just 1. And then I was pregnant. But other than that, I was fine at the beginning.
Yeah. Okay, fine. So fairly straightforward pregnancy in that you were tired, but, everything was okay. And midwife appointments were fine. You were fine. Blood pressure was okay?
Yeah, blood pressure was okay at the beginning. It started to raise. Like after 3 to 4 months, it started to get a bit high. Yeah.
Yeah, so they were keeping
but I didn't need medication or anything like that.
You didn't need medication. Yeah. Perfect. So we're keeping a close eye on the blood pressure and just observing to see if any signs of any changes.
Yeah.
Fine. And so what changed for you in this pregnancy then? At what point did you think, something's not quite right? I need to get checked out.
Around 32 weeks again.
Okay.
I started to experience reduced fetal movements again.
Okay. So they offered you more frequent scanning, did they?
Yeah,
when
more
you came
scans, yeah.
Okay. And so with the reduced fetal movement, what was the management?
The plan of action was, again, induction at 36 weeks.
Okay. So you were going in regularly to have the monitoring?
Yeah, all the time. MAU again.
So
MAU every day again.
Every day? Oh,
yeah,
gosh.
Every day again.
So in the assessment unit, getting regular checks of baby's heart rate, which is usually done by monitoring with where they have the belts and the monitors attached to your tummy. And they basically will monitor baby's heart trace to see that everything is okay. So yeah, we get a nice picture of actually baby's activity as well on that heart trace. So were they all sort of normal as expected?
Yeah, everything was cool.
Yeah, good. So, and coming in so regularly, worried about baby's movements, how did you feel like the staff were towards you?
Some of them were nice.
Yeah.
Some of them were a bit funny, but I didn't really care. I was there just to make sure my baby was safe. So any little sly comments, I just ignored it, to be honest.
Yeah. What kind of comments do you mean that were said?
Like, oh, she's here again, but she looks perfectly fine to me, or it's all in her mind. One of them said that I was delusional and that I was a bit paranoid and a bit anxious from what happened previously.
Yeah.
But I was just like, oh, whatever, I don't care what you
as a healthcare professional, I would never want a woman to feel like, you know, we were sort of talking like that behind your back. And I think as well, perception is very personalized. So actually how you feel movements are, I can never, you know, or how if you think something's wrong, I can never feel that for you. So actually we have to be very aware of like the language that we use around women as well. Trying not to demean their experience. So I'm sorry that someone's
But literally after those comments were made, I said to myself, you know what, moving forward for the rest of this pregnancy, I refuse to talk to any obstetric consultant or any midwife who doesn't have a child. Because they were just undermining something they didn't know. Like, I'm not a textbook. Yeah. If you've never been pregnant before, you cannot tell me how I feel. So moving forward, any midwife they assigned to my name had to be qualified, which meant they had to have a child. Like, because of what I went through the year before, they just accepted my request and they were like, you know what, we're going to give you what you want. And then
so I think it, you know, it helps if you feel listened to. That's the main thing. I think once you feel listened to and you're not feeling like you're being fobbed off, or you know, you can empathize with someone even if you haven't been through their situation, and still be kind and, you know, like treat someone with respect. I think that's the ultimate thing that I would sort of think about if I was in that situation, is like, you know, if that was me, my sister, my, you know, somebody that I loved, would I think that was appropriate to say? Or, you know, that kind of thing. So interesting. So did you feel involved in the decision making around having baby around 36 weeks?
Yeah, I did.
Fine.
And I was happy because I was able to prepare, like get childcare for my other children and pack my bag and not. So I mean, like when you just go into labor, like so sometimes you're not always ready, because I knew, okay, 36, I'm going to be admitted on my 36 weeks. Like I knew what was coming.
Okay, fab.
So it was nice.
So they discussed with you your options for birth at 36 weeks. What options did they give you?
Cesarean or induction.
Okay. And what was your preference?
Induction.
Okay. And why is that?
Because I've just always heard that cesareans are just really painful, and it's a major surgery if you don't need to have it. So I was like, if it's a life or death situation, I'll happily have it. Yeah. But I'm not going to pick. I've had 2 successful vaginal births, so hopefully this is going to be the 3rd. Yeah. Yeah. Okay.
So that's essentially, if we are planning to deliver baby, especially around 36 weeks, then you have options for, or you might have, depends on your clinical picture, what other risk factors and other sort of history that you have. In Natalie's case, she had the option of induction of labour or a cesarean section as an elective procedure, which means basically planned. And so given her history, Natalie was happy to try for an induction of labour, and that's the route that she went down. So shall we talk about that next then? What happened? Stay tuned. So how long was it then, I guess, from starting the induction to baby being born? What was the kind of time frame that we're looking at for the induction process?
I got inducted on Friday morning, the 10th of June, and I gave birth to Cairo on Sunday evening, 12th. So 2 days,
But we had to bail.
Yeah,
we had to bail a little bit on this one. Okay, so I guess it's 2 parts. So let's talk about kind of the actual induction, getting in and kind of getting that started. How was that process?
Putting the pessary in was okay because I had done it before, so I knew what to expect.
Okay.
Yeah.
So inductions, there's a couple of ways that you can have an induction. You can have a hormonal induction, which is where they have a pessary. And that looks like a little flat tampon on a string. And that gets put in, and that sits in for 24 hours unless it needs to be taken out sooner, which it did.
Yeah, it did.
And that generally it just emits some hormone and tries to sort of get the body prepared for labour. It doesn't necessarily put you into labour, except in your case. But it normally just sort of softens and ripens the cervix and gets it ready for that kind of thinning out and opening stage. So for most people, it can sit in there for 24 hours and you might notice that there's some changes to the cervix, but not necessarily the start of onset of labour and contractions. And then the other way is mechanical, which is then what's called what you had the
Cook's
Cook's catheter, or a balloon induction, where they just sort of insert a catheter that would normally go into your bladder, but it gets put through the cervix and inflated with water, and it just sits and adds a bit of pressure on the cervix, which can then try and stimulate the signs of labor and contractions. So mechanical induction with a balloon, or a hormonal induction with a pessary or a gel or some other formulation of hormonal induction.
Mm-hmm.
So you had the pessary from the get-go.
Yep.
Yeah. Okay, great. Tell us about that.
So when I had the pessary put in, within like 2 hours, I started to contract.
Okay.
Like go into full blown, like 5-minute contraction, then 3 minutes, then 1 minute. And
no hanging about with you.
Cairo couldn't take it.
So it worked quite quickly then for you.
Yeah, it worked really quickly.
Why do you think that was in your situation?
I think because I had a baby not that long ago, so my body like really remembered what to do.
And that definitely can have an impact on how quickly the process moves for some people, and some people are more sensitive to a hormonal induction as well. So that's why we monitor very closely when you've had the induction started. We monitor baby's heart rate very closely so that we can identify if there is a change. And that seems to be what happened, is they were able to see, okay, you were having more frequent contractions.
So they literally left. So I was in a side room on my own with my friend. And then I just heard doom, his heart rate really slowed down. And luckily the midwife was passing. And then she looked for her, what is that noise? And then she quickly ran over. And then she hit the emergency button because his heart rate dropped to 15.
Okay.
Yeah, so he really wasn't managing the induction well. The crushing was driving him mad.
He didn't like the squeezes.
Yeah, he didn't like it. He couldn't take it. Yeah. So they had to quickly stop and terminate the labour. They had to give me an injection to stop all contractions. Yeah.
And this is one of the things, that's why we look out, because we might have to intervene and completely stop the contractions or slow things down a bit to give baby a chance to catch up. So bearing in mind, a couple of the reasons why this can happen as well is if induction is, before babies are due, so they're a little bit smaller, and obviously we know as well that Cairo was on the smaller side of normal, so they don't have the sort of same reserves to cope with a strenuous labour. And sometimes if we like to ease into it, so induction processes are supposed to sort of take a little bit of time because we're trying to force the body into labour, but in stages essentially. If it happens too quickly, then babies don't get a chance to recover in between the contractions, and they can get quite stressed. And they display that stress by dropping their heart rates, which is what
Cairo
explained that's happened with Cairo. So we like to monitor for that. And as soon as we identify that, as with what you've said,
they took the
pessary out. That's the first thing. Take away all the stress for the baby. So we take the pessary out, and then what do they do next?
They gave me an injection to stop the contractions.
Yeah, so it's a medication called terbutaline. It's commonly used to try and slow or stop the contractions, and it's called a tocolytic medication to stop contractions, essentially. So really, really good that they acted quite quickly to do that. And then what happened after that?
Then they just left me. They just left me. They left him to recover for a while.
Fine.
So it's all Friday evening I had no medical intervention. All Saturday I had no medical intervention. They were talking about putting the pessary back in on the Saturday morning, but I refused. I was like, I'm not doing that again. He can't take it. I'm not doing that again.
Okay.
So then the agreement was on the Sunday we was going to put the Cook's catheter in, which we did.
Okay.
And my waters went.
Okay.
Yeah, so they had to take it out. And then they were supposed to give me a cannula so that I could start my antibiotics there and then, but they kept on hitting the valve.
Okay.
Yeah, so luckily I knew all the midwives from the MAU unit. Yeah.
Frequent attendance, when you come regularly, you tend to get used to a few faces, and they get to know you, and you get to know them.
kind of figured out who cannulates the best, who takes the best bloods. So luckily the midwife who cannulates very well, pain-free, I went to her. She did it straight away.
Oh, that's good.
And then she said, you know what? I said to her, listen, it's Sunday, so I'm not eating hospital food for Sunday dinner. So I'm going to go downstairs, meet my mum or my children, hubby, and go downstairs, get my food.
Yeah.
And then I'm going to come back upstairs. But at first I was like, let me go downstairs, and when I come back up, you can cannulate me after. And then she was like, no, we have to do it now. So God forbid there's a medical emergency when you're downstairs. we can intervene.
Got access,
Yeah, we got access. Yeah. So
perfect. Good.
I went downstairs and then got my son the dinner, was playing around. It was a nice summer day. We was on the grass having a little picnic.
Yeah.
I was by the way, I was in active labour at that time. Like I was contracting, but I'm good with pain. So I was like, you know what, give me a second when the contractions came. But then after that, I was okay again.
Yeah.
So then I was like, you know what, I'm spending too much time down here, guys. I need to go back upstairs. So I went back upstairs.
Yeah.
And then the midwife who brought me to the door, she was like, when you come back, meet me by the door. So like buzz in and ask for me so I can let you back in so we know you're safe and back in your bed.
Yeah.
So I'm like, okay, perfect. No worries. So then I got back upstairs. Bear in mind, I ran up the stairs to go back upstairs because I'm like, this baby. I'm like, this baby's coming out vaginally. Like, I need to.
You were trying to make some room and do. She was doing the labor dance. That's what I call. I was
like, you need to come out. That's what I was doing. I was doing curb walking, everything. I was like, he is coming out vaginally today.
Good.
So then, but when I was walking up the stairs, I felt like a sharp pain.
Okay.
And then straight after the sharp pain, I felt like elbows like turning. So I'm like, what is he doing? Like, why would you turn now? Like, why you've been head down all these months? So why are you turning?
You might have done a big flip.
So I'm like, why are you turning now? Like, why would you go breech now?
Yeah.
I'm like, you're just giving me problems. So then I literally got in the doors. Then I said to the midwife, I'm like, midwife, I think I'm bleeding.
Okay. So you felt something?
Yeah, I felt like a warm sensation. And she looked at me and she's like, please don't say that. And I was like, no, like, I actually think I am. So she's like, well, quickly get in the room, like quickly. Yeah. So we ran to the room and then she's like, take your clothes off, like get naked right now. So I took all my clothes off and then like, I just started hemorrhaging, like I was losing loads of blood.
So there's blood
just pouring out like, by this point, and like big clots just slapping the ground, like falling out. So then by the time I even got to ask any questions, she literally hit the emergency bell. Yeah. Okay. And then like all the midwives, doctors, surgeons, all just came running. I've only seen that on like TV series. I've never actually seen
Grey's Anatomy, Holby.
Yeah, like
you see the drama.
24,080. I've never actually seen that in real life. So I was scared because I'm thinking this must be for that amount, because I think there was like 10 or 12 people in my room by this point. Yeah.
And so just to kind of enlighten people. So when there is an obstetric emergency, so there's an emergency bell on the wall, when that gets hit, everyone comes in because everyone can take on different roles. Lots of things usually have to happen at the same time during an emergency. So someone's like, we need to get some bloods. We need to put another cannula in. Somebody's like, we need to measure the blood loss. And somebody else is like, we need to be documenting the times that all the medications are being given. Somebody's giving the medication. Someone's making sure that theatre is being called. So although it can be quite scary when lots of people do run into the room, it's really important that they are there because then everyone has a role that's assigned to them. And that helps for us to all be multitasking while making sure we're caring appropriately for mums. So scary, but it is necessary. And then as soon as we can sort of step the situation down, people will start to sort of disappear quite quickly. So normally if like we're worried about baby's heart rate, we see that big drop, lots of people come in. Once like 2 or 3 things have been done and everything's settled down, then literally everyone leaves again. You're like, oh, where did everybody go? Yeah. So it can be that quick that everyone comes and as quickly leaves as well.
So I had like the pediatricians there. I had the neonatal team. Then I had the surgeons. Then I had the midwives. Then I had the lead midwife. So it was like, it was like a lot of different people. Yeah,
it's very common in emergencies, so that we can make sure all the things that need to be done are done in a timely manner, so that we're not wasting time. Because that is an emergency. Yeah. When the placenta starts to come away from the uterus, it leaves an open wound. Essentially, it leaves a big gap. And the blood is flowing through that gap. So that's why we have to move very quickly, because it means that less blood is getting to the baby and blood is leaving the mum as well. So it can be quite scary, but we are very well trained to manage obstetric situations. Did you feel it was managed quite well?
Yeah, but luckily I didn't have a concealed abruption.
Yes. Oh, yes. So we should probably talk about that, because actually in Natalie's case, it was an obvious over abruption, and that is where you can see the bleeding. It's very obvious that, that potentially the placenta is coming away. With a concealed abruption, it can be that actually you don't have any obvious bleeding, but you might have abdominal pain, sharp pain, or just the uterus goes really hard and stays hard. Some people will be having like labor contractions during this, but then they're like, no, that's a continuous pain I'm having and a continuous hardness of my belly. In those cases, we do advise, if you're not at home, if you're not in the hospital, then you need to get to the hospital as soon as possible. Speak to the triage as well, your hospital's triage, because they may advise you if you need to get an ambulance on an emergency call. So yeah, do act quickly if you have any suspicions or doubts that you've got a constant firm hard tummy and pain. That is when we would advise you to get to the hospital as soon as possible. Yeah, it doesn't happen very often, but as I say, we're very well trained to deal with emergency situations like that. In Natalie's case, she was in the right place at the right time.
Yeah, literally.
Had a great midwife looking after her as well, who was like, right, she was so on it. She got the team in there and they got you to theatre quite quickly, didn't they?
Within from the abruption starting to me being in the theatre, about 6 minutes.
Yeah.
They didn't want to give me a general anaesthetic because they didn't know if I'm going to wake up because I was losing so much blood. They didn't want the body to go into shock.
Yeah.
So they were like, let's keep her awake, but let's just like, after a while when they were spraying me, like, can you feel it? Can you feel it? It was taking too long for me to go completely numb.
Yeah.
So I was numb, but I could still feel, I could still feel like the car and like the moving of all the organs. I could feel everything basically like a. It felt like it kind of felt like a washing machine.
Okay, so that's a normal sensation to feel when you're having a cesarean section. What we don't want you to feel is sharp pains, so where they're making incisions, and that's why they sort of test the block, is what they call it, how numb you are from the medication that they're giving. And so it can mean that you're still going to feel touch and movements, but you shouldn't feel sharp cuts. And so that's what they were trying to do, is get Natalie as numb as possible, so that she wouldn't be feeling those sharp cuts. That.
So I felt the initial cut. It was a little bit painful, but it wasn't complete, because by the time they cut me, I was numb then. So once that they were in, I was numb. So I could just feel like movement. But they actually got him out in like, I think it was like 50 seconds. But I did forgot to tell you. So when they cut me, because he had turned, his head was literally up here.
Oh, so he was...
his head was up here.
Cheeky boy.
And he was literally sitting like this. So when they cut me, his hand came out like this.
Wow. Yeah.
So they were like...
Superman.
so then they were like, oh my God, because like, if we didn't see that, we could have cut his hand kind of thing.
Yeah.
So then what they had to do was they had to give me a teacup.
Oh, okay.
Yeah. Because they when they were putting their hand in to try and feel his head.
Yeah.
You said they like to take babies out head first.
If they can, they like to get babies heads
so
out
they were looking for his head and couldn't find it, so they had to cut me again. So now I have your T-cut.
So in that emergency situation, it's not sort of a let's try and gently bring baby out. It's like we need to get baby out because we want to save this baby's life. So it's like by any means necessary, they will do everything to save your baby's life. And it sounds like that's what they did, because instead of just having a nice tidy incision here, they decided to cut as well up there, just so that they could get baby out quicker without having to stress too much.
But luckily they only cut up on the inside, not on the outside.
It never is on the outside. It's always the actual uterus itself. So don't be alarmed that it is the inside of the tummy and the uterus. So how was Cairo when he came out? Because obviously, having kind of had the abruption and then trying to get him out quite quickly.
He was non-responsive when he came out.
Okay.
So
that's not a surprise, is it? Like obviously he's a bit like, what's going on here?
So when he came out, the whole room was in mute. Everyone, the pediatrician team was working on him, like giving him his CPR and stuff. So I was like, is my baby alive? And then there was just no response. And then like a couple minutes later, I heard him cry. So I felt some kind of relief.
Yeah, I bet.
Yeah. But I was just like, how long am I going to be on this table for? Because by that time, I feel like I've been on the table like 40 minutes. Because every time they would go to like repair somewhere else will start bleeding.
And I think, cesarean repairs can take sort of, depending on what's happening, what they find when they go in, it can take 30 minutes to an hour to complete the repair after baby is born. And then obviously having to do the extra incision that they did, they would take a lot of time to make sure that, everything is repaired as it should be. And then they like to check as well that there's no damage to any of the other structures, especially in an emergency situation where they're trying to get baby out very quickly. And one of the risks for a cesarean section anyway is damage to surrounding organs. So it can happen even with the most cautious kind of cesarean birth, but when it's an emergency and it's life or death situation, it can be a higher chance of that happening, and a higher chance of lacerations to baby, like you were saying, especially if he's coming trying to do this, all of this.
He couldn't wait to get out.
He was having a great time trying to come out himself. He's like, I'm tired of waiting for you guys.
He couldn't wait to get out.
So he cried.
Yeah, he cried. Yeah.
And sort of, how do you sort of remember how quickly you got to see him up close?
Yeah, I got to see him, but I didn't have the strength to hold him. Yeah,
fair enough. So he got to stay with you.
He was just here, like I was lying there, and then he was just literally here looking at me.
Yeah. So, you know, like this kind of situation is quite scary, but actually the really great news in Natalie's case was that actually baby responded very quickly to the neonatal support that he was given after birth, and he got to stay with Natalie, because sometimes they like to take babies to the neonatal unit if they've got significant concerns about, you know, baby's condition at birth. But it sounds like, you know,
blood was covering.
He was good. So actually,
he was literally covered.
Really thankful for that, because it's a scary
and I
story,
actually didn't need a blood transfusion.
Oh wow!
The blood was there. I could see it.
Yeah, they were ready.
Yeah,
for it.
They had like 4 boxes of blood, like right now. I could see it in like the corner of my eye. But they did the thing where they recycled my blood.
Yeah, so that's called a cell salvage. So it's like a filtration system where they gather the blood that's that Natalie's lost, and then they filter it and basically re-infuse it back into Natalie. So that is one really good way of trying to minimize blood transfusions, because they're not without risk as well. So it's really useful if you need it. Absolutely, we advise that you go for it. But if we have a capacity to actually refilter your own blood and put it back in, it's yours. It's even better. So that's
happy about
that. Yeah, perfect. So then in recovery, how was that? So how did the surgery end, and the discussions that were had with you afterwards?
I was just numb for a long time. Yeah, my legs, because of the spinal tap. But in recovery, I was fine. But I was a bit naughty in recovery because I kept on drinking water. Because I know you're not supposed to drink.
Well, actually, a lot of evidence has changed around that now. So usually, obviously, your case was quite complex in that, it was a really, really sudden emergency and all of that. And potential for needing to go back to theatre can be quite high with cases like yours. But actually, most times, once we get women into recovery, we offer them some water within about half an hour of being out of recovery, bearing in mind that by the time the surgery is finished, they get you on a soft bed, they get you into recovery. It's probably been about 20 minutes, half an hour by the time you get to the bedside and we get to giving you water.
Yeah.
So a little bit of time has passed. Yeah. I mean, you probably were quite thirsty because you lost the blood, a lot of blood as well. So it's quite normal to be thirsty, and it's quite normal for us to give you water to start with. And then if everything's settled...
No, but like they gave me water, but I was like, okay, I need more. Like I probably drank like 3 off the little jugs with the blue lids.
Yeah, the blue lids, classic. Yeah.
Literally 3 of those jugs. I was so thirsty.
Yeah, and blood loss can do that. So it can make you quite thirsty. Your body is telling you that something is missing, essentially. It's like, we need to recuperate.
Yeah.
So it's not a surprise.
This wouldn't let me eat.
Yeah.
Yeah.
And then eating, in your case, we would probably want to wait quite a few hours before we kind of suggest that you can eat. But for a routine sort of cesarean section, we're quite happy to offer tea and toast within an hour of you coming out of theatre.
Lucky.
As long as you, if you've kept your water down and you've not had any kind of real issues, then we offer tea and toast. That's your staple NHS post-pregnancy meal. So yeah,
I wish.
Toast, yeah. But yeah, that's thank you for sharing that, because that was obviously was that a traumatic experience for you?
Very.
Yes. I don't want to make assumptions,
but they didn't.
I would have thought yes, that's quite traumatic,
very,
but obviously.
But they didn't tell me, like, I didn't understand the extent to how traumatic it was until I'd been through it, and I had and people like a debrief team came to talk to me about it on the ward, and when they were talking like about the mortality rate and stuff, that's when I was like, whoa, okay, that was really an emergency. But at the time it was just a thing where, let me just get through this, I don't care about the stats and stuff for now.
Of course.
After we can talk about that.
So
but I'm glad that I made it. I'm here to tell the actual story.
And thank you for coming to do so. And I think what's really important from what you've just said is about the debrief team, so a team of people coming to talk to you about your experience and what actually happened. And sometimes that needs to be like an hour, the next day or something, really, for you to process all of that information as to, oh my gosh, I just had a baby, 1, and 2, that wasn't what we expected at all, and 3, like, you know, I lost a lot of blood and this, that, and the other happened. You're still trying to process that in your head. So it's really valuable that, you know, if you do experience something like this, that you ask for a postnatal debrief, even before you go home, just so that you can kind of figure out what's happened to you and how you can sort of heal from that, both emotionally, mentally, as well as your physical healing process as well. So it's really important that we do, you do have a debrief afterwards, and you might need a second debrief. So I feel like it's not one and done. Like it's a process of recovering, because it is a trauma that you've gone through. If you've gone through an abruption, it is a trauma. And, you know, you'll have questions and they might not come for a few weeks in your mind. You know, you've got a new baby, you're thinking about, I just need to get this baby, like, you know, fed and dressed and all of that. You're thinking about all of those. And then you, in those quiet moments, you might have time to reflect and be like, oh my gosh,
I went through that.
I went through it, you know, and oh my gosh, like, will I go through that again? Like, these are all very normal questions. So it's really important that you, you know, if you do have questions like that as well, whenever you have them, jot this down, write it down, so that you can come back in a later postnatal appointment and go through those questions as well.
I feel like they had questions too, because they were like, how did she manage to have 2 40 placentas back to back?
Yeah. And sometimes we never know the answer to that.
So they wanted to do some research too.
Yeah. Thank you so much for that. I think it's really valuable for us to get a bit of insight from your perspective as someone who's been through that. So just to kind of conclude the abruption and kind of this emergency cesarean story, what advice would you give to women? I know it's not always easy to pick up, like, you know, something like this, but what advice would you give to women who kind of been through that process of the regular triage, induction, abruption, cesarean? So many.
I would say the reduced fetal movements for me is always the key that something's wrong. Like, don't ignore that. Don't like, because at first I was putting it down to, you know, I've been a bit busy, you know, maybe my body's just tired. But then I realized that his movement has nothing to do with how tired I am. Do you know what I mean?
Yeah.
So I feel like never, like, when your baby's not moving, you need to follow that up. There's a reason why your baby's not moving. Something's wrong, but they can't tell you that. I feel like they stop moving to let you know something's wrong.
Yeah. That's great advice.
Yeah. So like, always follow. Don't Google it. Don't Google
is a scary place.
Don't Google reduced fetal movements. Like, and I know not everybody has the time. Like, I had to go and sit in the maternity assessment unit, but let's be honest, your job's always going to be there. Like, don't say, oh no, sorry, I can't go because of work. Do you know what I mean? Like, if something's wrong, you need to, like, if you think something's wrong, you need to go and check that out.
Never stay at home concerned. That's what triage is there for. The triage service is 24 hours a day. There's always someone there. It's always manned. And if you can't get through on the phones, then you just need to show up and get checked over. And you know, you will know your body better than anybody. So, you know, if they are doubting you or whatever it is, and you feel that something's not right, be bold to say, no, I'm not happy. I'm not happy. And, you know, if they're like, well, we've done this, this, and this, and you're still not happy, then ask for a second opinion, ask for another review from the doctors, and just keep going until you feel like you are being heard and you're being listened to. I think that's the.
And you're allowed to change doctors.
Yeah. You can ask. You can ask for a more senior review. Yeah. You can ask for, because they will have a few doctors on staff as well. And I think it's really important that you say why, because if they never know that you don't feel listened to, you don't feel heard, they can't improve as well for themselves. And I think that's important, isn't it? Yeah. It gives them an opportunity to reflect on their own practice to make sure that they do, you know, the right thing for women.
You don't even have to have a problem with your doctor. You could just literally say, hey, do you mind if I ask someone else and see what they think? And most of the time they're like, yeah, no worries.
Yeah, absolutely. And I think that's, you know, there's a way you can do it that is bold and forthcoming and forthright, but still respectful. I think that's the main thing, because everyone's coming to work to do their best as well, and they don't always get it right. We know that. I try to bring my best,
because everyone was laughing, because on the, like, when I was in my theatre, like in surgery, I kept on asking everyone, like, have you eaten?
Yeah, oh, that's kind.
when last did you eat? Because I know the midwives always used to complain that they don't get a lunch break. So in my head, I'm thinking, if you're going to do surgery on me, you better have eaten. Because I don't want you to be, I want your best game. I don't want you to be in the middle of it and then you're thinking about chicken and chips. No, like, but then when I was asking them, a lot of them was like, wow, like nobody's actually ever asked me that before. But I know that when I'm hungry, I can't perform at my best. So that's a very like, fair point. The midwives would literally come in my room and have their lunch break because I made sure they ate.
Look at that. Yeah, I know. Patient who is looking out for her healthcare professionals as well.
Because I know how it is when you're hungry.
Yeah.
You can't perform at your best when you're hungry.
Yeah. Just take home, like, for us as healthcare professionals. I was going to ask you, like, what would you want us as healthcare professionals to kind of take from, your care and your situation? Eat well.
You need to eat, man. You need to
eat well. Yeah, and go on your breaks if where it's possible, where it's safe to do so. Definitely go on your lunch breaks
and talk about, like, obviously don't go and tell your whole family about your patient's story, but if you feel triggered, for example, the midwife that looked after me, she had a placental abruption before, so I know we became very close. We're friends now, we're really good friends now, but I know that my abruption triggered her past trauma. So like, it's important that even as a midwife or as a doctor, if you see something traumatic, talk about it. Like, go to your senior and talk about, like, can I talk to you about what I saw? Do you know what I mean? Because you don't want to bring work home.
And that's really valuable, because actually we offer debriefs for our women. We should also have that, and I know that a lot of hospitals do that. Like, we have that service in the hospital I work in, so it's really important that you are making sure that you have had an opportunity to talk about what you've experienced, because it is a trauma for you as well. So we do need that to look after ourselves as well, and it helps us to reflect and be better practitioners for when we encounter other women in similar situations as well. So thank you for that.
That's all right.
So we've come to the end of Abruption. Hopefully it's not scared too many of you, because this is a wonderful
It doesn't normally happen.
It's not a common thing, but it is something that we train on it, and we do annual updates and annual training to make sure we can pick up on those signs and act very quickly to support mums and babies. So don't be concerned. All we're trying to do here is make sure that you know how to speak up if you are concerned about anything. And if you've been through something like this, then you can be part of our community where you can meet other women who have similar stories. So thank you very much, Natalie, for talking to us about this. We're going to talk about our next topic is postnatal sepsis.
Yes.
So stay tuned.